hospital, which are basically what I have to discuss here is inotropics and vasopressor medications. And also we have some medication safety tips that we have to discuss today. And there are some also situations or scenarios where we can actually prevent medication administration and for safety reasons. So welcome to the drugs and calculation part 1. Okay, the first lesson for us is our objective is to understand what is a drug, to discuss the metric system, to discuss the apothecary system, to discuss the household system, because usually our household system, it's very important that we have to know, because sometimes we are using actually some of the food that the patient is taking in, like spoonful of yogurt, so it should not be 1 spoon in your intake and output. Then we need to learn the conversion. So I have some examples, and you need to convert it. To review, learn, and practice the calculations of infusions. And as what I told you, it is basically vasopressor and inotropic agents. To review, learn, and practice the calculation of drugs and infusions used in the area. So there are medications that are actually available in our hospital setting, which we are encountering daily. So to be able for us to miscalculate the dosages, so I will give you some tips on the formulas that we have to use during the calculation. So a drug is also called a medicine, is any substance taken by mouth, injected into the muscle, the skin, a blood vessel or cavity of the body, or applied topically to treat or prevent a disease or condition. So even if it is ointments, it is still considered as a drug. In calculating for any drug, one must know how to convert values within and among systems, and at present, the International Systems of Unit, or the so-called as SI, is the internationally accepted scientific system in expressing length, mass, and time, and through the base of units of meters, kilograms, seconds, and this method replaced the old CGS system, which used centimeters, grams, and seconds. So we are now usually using the International System of Units. Before, like for example, we are using the CC. Now it's actually ML. We are using the ML. It is the International Systems of Units. So we'll talk about the metric system. It originated actually in France, and the metric system or decimal system is based on the meter, which is the unit for measuring length. And from the meter, the units, for example, for measuring volume and weight are derived. So I want you to remember this, that the length of a meter is 1:10,000 of the distance between the equator and the North Pole, which measured along prime meridian. And the volume liter is defined as the volume of a cube, each side bearing 0.1 meter or 1/10 of a meter in length. So even the volume or liter is also calculated according to the length. And weight in grams defined as the weight or the mass of pure water of 4 degrees centigrade contained in a cube of which side is 0.01 or 1:100 meter in length. So what are the metric units of weight? So we have here kilogram is equivalent to 1,000 grams. Please take note of these weights and equivalent because we will have some questions and I will ask you to calculate, and hopefully you can still remember this. 1 kilogram is equivalent to 1,000 grams. 1 gram is equivalent to 1,000 milligrams. 1 milligram is equivalent to 1,000 micrograms. 1 microgram, or the so-called UG, is 0.001 milligram. and 1 kilogram is equivalent to 2.2 pounds. So later we will discuss on the calculations of metric units of weight. So also this one, please make sure that you will take note of this. 10 millimeters or mm is equivalent to 1 centimeter. 10 centimeters or cm is equivalent to 1 decimeter. 10 decimeters or dm is equivalent to 1 meter. 10 meters or m is equivalent to 1 decameter. And 10 decameters or dm is 1 hectometer. And 10 hectometers or hm is equivalent to 1 kilometer. And 1 inch, please do remember that it is 2.54 centimeters. And for 12 inches, 1 ruler is equivalent to 1 foot. So 1 liter is equivalent to 1,000 millimeters. 1 millimeter is equivalent to 1,000 microliters. And 1 microliter or UL is 0.001 ml. So these are the metric units for volumes. So we'll talk about the apothecary system. Apothecary system is actually used during the time of Flintstone. If you can still remember Flintstone, the cartoon character. So it is an arbitrary method. Apothecary's measure is a system of graduated liquid volumes originally based on the minim. Before they will tell you, give 1 minim of syntocinon. So this is actually from the apothecary system, formula equal to a drop of water. This, however, has been standardized to 0.06 ml. In weight, this method formally based on heaviness on a plump grain of wet. Okay? This measurement has now been standardized to 65 milligrams is equivalent to 1 grain. So you cannot hear anymore any physician that will ask you, please sister, you have to inject 1 grain of epinephrine. Okay, so you cannot hear that anymore. Instead, it's actually milligrams. Okay, small Roman numeral are used for drug dosages in grains. S is the abbreviation of 1/2 and is used in the Roman numeral. So there are actually some of the things that I just wanted you to know, but actually it's not really necessary for you to take note. But there are things that you can actually take note. But why I'm discussing this? Because we are talking about the metric system, the new system, and also the apothecary system. Okay. So 1 grain or the 20 grains is 1 scruple, 60 grains is 3 scruples on 1 drum, 480 grains, 24 scruples, and here 12 ounce is equivalent to 1 pound. So we are actually, before 1970s, they're still using for volume the meaning. So actually they are asking for those patients who are post the partum, they wanted to contract the uterine muscle. So usually they will something like tickle the uterine muscle just to contract. They will ask, give 1 minute. So it is actually an apothecary system. So if you don't know what the doctor is actually saying, you cannot administer this medication. So now you can still hear pints, especially for ice cream, or 1 or quart or gallon. These are not so much used now, but now we can have the quarts, the pints, or the gallons. Okay. So we have actually differentiation between the metric and apothecary. So if you will say 1 ml in minims, it's 16.23 minims, and 0.06 ml is 1 minute, 30 ml is 1 fluid ounce, 500 ml is 1 pint. For the weight, 1 milligram is 1/64.8 grain. 64.8 milligrams is equivalent to 1 grain. 1 gram is 15.432 grains. 31.103 grams is equivalent to 1 ounce or 400 80 grains. So let's talk about the household system. The household system is actually very important because when you are feeding your patient in the hospital setting, you are using spoons, you are using glass, tea glass, and also you are using like the container of the food, like the yogurt or the juices. So you need to make sure that you will not write in your intake 1 glass of laban, 1 glass of 1 cup of yogurt. It should be specified because your intake and output should be calculated in ml. Okay, so we can actually be clear that your calculation is according to the volume of fluid. So 60 drops. So if you are administering medication by drops to an infant or child, 60 drops is 1 teaspoon. Okay? 3 teaspoons is 1 tablespoon. 6 teaspoons is 1 ounce. 2 tablespoons, 1 ounce. 6 ounces, 1 teacup. 8 ounces, 1 glass. 8 ounces, 8 ounces also is 1 measuring cup. It's the same. So approximate equivalent to remember, okay? So if you're saying I administer 1 drop of Pevadol to a newborn baby. So because since we are using now the metric system, so please put in your intake, it's 0.06 ml. And for 16 drops, it's 1 ml or 1 cc, okay? 1 teaspoon, okay? 1 teaspoon is 5 ml, 2 tablespoons, 30 ml, 1 ounce, 30 ml, 1 teacup, especially those patients who are taking tea or coffee, okay, Arabic coffee or the tea, then they are usually, you can ask the patient, how many teacups did you drink today? Okay, so if he will say 5 teacups, so that means 5 teacups multiplied by 180 ml because 1 teacup is 180 ml. 1 glass is 240 ml. 1 measuring cup is the same with 1 glass, which is 240 ml, and 2 measuring cups, it's 500 ml. Okay? So please make sure that you can take note the household plus the metric system. Forget about the apothecary. It's during the Flintstone time. So let's practice. I want you to unmute your microphones, okay? The last time during the ACLS, I still owe chocolates to one of those participants that she really answered well. So I will, inshallah, I will see you, Miss Maricel, who give, inshallah, the chocolate for that participant, okay? So let's
Okay, ma'am.
practice. I guess I owe her 2 chocolates, right?
Carmina.
Okay. This time, okay, practice. Convert 85,500 microgram to grams. Okay, you have 30 seconds. Yes. Yes. Okay, who's this? Okay, Salvi, we'll see. Okay, 0.0855 grams. Okay, the first thing you have to do is, of course, you have your micrograms, and then 1 microgram is 0.001 milligram. That would become 85.5 milligrams over 1 microgram. So you will cancel microgram and microgram, then it will be 85.5 milligrams times 1 gram. 1 gram is equivalent to 1,000. That gives you 0.0855 grams. So Salvi, congratulations. So another question for you. A patient is prescribed 200 milligrams of furosemide IV The ampules available contain 250 milligrams in 10 ml. What volume containing the drug do you need to administer? So we are now talking about the volume, okay? So we have here the dose, which is 200 milligrams. This is what we want. And what is in? We have furosemide 250 milligrams per 10 ml. This is what we got. So what is the answer? So we are talking about what volume containing the drug do you need to administer?
8 ml.
Okay, the patient is prescribed 200 milligrams of furosemide IV. The ampules contain 250 milligrams in 10 ml. So what volume?
8.
Okay.
8
Who's
ml.
8 ml? So let's check. Who's this? What's your name?
Batul.
Batul. Okay, we'll see Batul. Okay, very good, mashallah. Batul, from which hospital you are?
Prince Saud bin Jalawi.
ESBJ. So, inshallah, you will have chocolate next week.
Inshallah.
Okay, if I don't have Alzheimer. Salvi, from which hospital are you coming from? Okay, King Faisal. Okay, inshallah, I will give to Mr. Ayman. Okay. So next, so you're enjoying your calculation so far? Okay, another question. Sorry, what the line? The patient is prescribed 250 milligrams of aciclovir IV. Aciclovir has to be initially reconstituted with water for injection, then added to a bag of compatible infusion fluid, giving a final concentration of 5 milligrams per ml. How much infusion fluid should be used to dilute the reconstituted aciclovir to achieve this final concentration? So again, a patient is prescribed 250 milligrams of aciclovir IV. Aciclovir IV has to be initially reconstituted with water for injection, then added to the bag of compatible infusion fluid, giving a final concentration of 5 milligrams per ml. So how much infusion fluid should be used to dilute the reconstituted aciclovir to achieve this final concentration? So you have the dose is 250 milligrams, and what is the final concentration is 5 milligrams per ml. So how much infusion fluid should be used to dilute?
50 ml. 50 ml.
Who's this? The first one?
Nora.
Noura. Noura from where?
From Prince Sultan.
Mashallah. Noura from Prince Sultan. Okay, we'll see. Mashallah. Okay. You have chocolate from Maricel, inshallah. I think I will give to Maricel. Okay, mashallah. Salve from King Faisal, PSBJ, and Prince Sultan. Thank you for your mashallah, your very fast hands to calculate. Okay, you have a calculator mind. Okay. Another question. 1% W/V solution means that in every 100 ml of solution, you will find 1 gram of drug. Therefore, how many grams of glucose would be there in 500 ml of 5% glucose? Okay, repeat. A 1% W/V solution means that in every 100 ml of solution, you will find 1 gram of drug. Therefore, how many grams of glucose will be there in a 500 ml of 5%?
5 gram.
How much?
5 gram.
Who's this?
Batul.
Batul again. Okay, inshallah Batul have quick thinking. So 5%, but you need to multiply, it should be 25 grams, Batul. So who got the 25 grams? 5 grams for you, sa, Batul?
Right.
Batul?
Yes.
Yeah, it's half-half. Who got 25 grams? Who got 25 grams? Nobody? Because we have 500 ml. So you have 5 grams, then you have to multiply it by 5. So you have 25, okay? So sorry, Batul, you only have half of the chocolate. I will eat the half, okay? Okay, another. 1:10,000 strength means that in every 10,000 ml of solution, you will find 1 gram of adrenaline. Therefore, how many milligrams of adrenaline would there be in 10 ml of 1:10,000 adrenaline? Repeat, 1:10,000 strength means that in every 10,000 ml of solution, you will find 1 gram of adrenaline. Therefore, how many milligrams of adrenaline would there be in 10 ml of 1:10,000 adrenaline? Who's this? Who? Who? Miss Misha? Saira? Salvi? What's your answer? Okay, who has the other answer? Okay, we'll see. Okay, the answer is 10 ml, okay? 1:10,000 means that 1 gram of adrenaline is dissolved in 10,000 ml. So 1 gram is 10,000, 1,000 milligrams is 10,000 ml, divided by 1,000, then you will have 10 ml. Sarah? You raise your hand, Sarah. Sarah. Okay, Sarah. Any question? Okay. So another question. Furosemide must be administered at a rate no faster than 4 milligrams per minute. How many minutes would it take to give 200 milligrams of this drug? So we have 200 milligrams dose. We have a rate of 4 milligrams per minute. Our furosemide here is 250 milligrams per 10 ml. So how many minutes? So we are talking about time. So how many minutes would it take to give 200 milligrams of this drug?
50 minutes.
50 minutes?
Yes.
Who's this? What's your name?
Asma.
Basma?
Asma. Asma.
Asma? Asma, from which hospital are you?
Al-Umran.
Al-Umran. Okay. What's your answer? 50 minutes? Okay, mashallah, congratulations. So I will care of Sister Jane for your chocolate, okay? So please take note
Thank
of
you.
the formula, okay? If you are talking about the time, especially in the minutes, so please take note, those in milligrams divided by rate, milligrams per minute, and then you will get the time, okay? So another question, acetylcysteine or Parvolex, 7.5 milligrams is diluted in 1,000 ml of compatible infusion fluid. This infusion has to be given over 16 hours. What rate should you set the infusion pump at in ml per hour to deliver this dose? Acetylcysteine, or the so-called Carbolex as trade name, 7.5 grams is diluted in 1000 ml of compatible infusion fluid. This infusion has to be given over 16 hours. What rate should you set the infusion pump at in ml per hour to deliver this dose?
62.5 ml.
Okay, who's this?
Nora.
Nura from where?
Prince Sultan.
Nura from Prince Sultan. Okay, yes, 62.5. So we don't actually 7.5 will disregard this because it is diluted in 1000 ml. So it is actually making tricks to you, okay? So the total volume is 1000 divided by 16 hours, then you will have 62.5 ml per hour. So another one, you are required to give a patient glyceryl trinitrate or the nitroglycerin as a continuous IV infusion at 25 micrograms per minute. You have prepared a 50 milligrams in 50 ml infusion. What rate should you set the infusion pump at in ml per hour to deliver this dose? So we are talking about how many ml per hour. So you have your nitroglycerin as a continuous IV infusion at 25 micrograms per minute. You have prepared a 50 milligrams in 50 ml infusion. What rate should you set the infusion pump at in ml per hour to deliver this dose? So we have your dose, 25 micrograms per minute, 60 minutes per hour, and then what we have got here is glyceryl trinitrate, 50 milligrams per 50 ml. So how many ml per hour?
1.5 ml per hour.
What's this?
مشاعل.
Michelle from where?
Prince Sultan.
Michelle from Prince Sultan. We'll see. What's again your answer, my dear?
1.5 ml
1.5 ml is
per
correct.
hour.
Okay, congratulations. So we have ended part 1. Okay, did you enjoy your part 1 as you are calculating? Hope you enjoy, okay? So we'll go to the drugs and calculation part 2. We have here emergency medications, dosages, formulas, and calculation. So according to your protocol, you have to follow the protocol of your hospital, which is an approved one, okay? So usually, so what I am showing this is actually based on the cardiac center, and this is also now being used with other centers like Omran and King Faisal, especially those hospitals who doesn't have the protocol for vasopressors and inotropic agents, okay? So for central line, the butamine 250 milligrams in 45 ml of D5 water or normal saline. Okay, these are the two most compatible IV fluids. But the first one is actually D5 water. But since our patients is we have a lot of diabetic patients, so to decrease the blood sugar, we are using the NS. So it is 5 milligrams per ml, but for peripheral line, there are some hospitals are actually starting peripheral line only in the ward if needed to do so, okay? And it's very low in dosage. It will not be the same with the central line because the problem with the butamine, once there is extravasation, then there will be burn on the skin and necrotic tissue will also develop to the patient. So 100 milligrams in 48 ml of D5 water, that would be 2 milligrams per ml. So your formula, when you are calculating the dose of your medication if you are being asked to run ml per hour. So the stock of the vitamin is 250 milligrams per 5 ml. So please do remember this formula, okay? Please take picture or anyway, I will share this to the clinical instructor, the PowerPoint, and inshallah, you will try to review it and they will not forget your calculations, okay? So to calculate the ml per hour, dose in microgram, usually the doctors will order 5 micrograms or by microgram, okay? Multiplied by the body weight of the patient. That's why our patient's body weight is very important. The first thing we have to do, including our vital signs, is actually weight and height, because these are very important to calculate the dosages of the drug. Then multiplied by minutes, how many minutes in 1 hour? So 60 minutes. Then times the total volume. So the total volume will be 50 ml, okay? So to calculate the microgram per kilogram per minute, because sometimes you will have ml per hour. And then as a nurse, you are usually checking how many microgram um, to check if really the running rate is correct according to the order of microgram per minute. So to take microgram per kilogram per minute, the rate in ml per hour multiplied by the stock in microgram divided by the weight, the volume, okay, 50 ml times the 60 minutes, okay? So this is how your formula should be, or the formula should be used in calculating the dosages, okay? Dosage and the volume which you have to administer to the patient. Note that peripheral dobutamine, the maximum concentration, will be used in patients with severe heart failure who do not have a central line in place and require urgent dobutamine therapy. But this should not be used in every day, like for example, or as regular, because if only there is a need, okay? Because really the extravasation is our problem. It will be hurtful for a patient. One of our experience with this is when we don't have the protocol yet. So each doctors have their own protocol and they are bringing it in the hospital. So the concentration before of the vitamin is double. So if you have 250, it will be 250, then it will be only in the total volume of infusion in the syringe pump is only 50. So it's very high dose. And what's going on, there is one patient who is a foreigner and there was an extravasation because there was no vein and the vein available is only on the foot. So the foot was having necrosis and almost the patient was amputated. Alhamdulillah, the patient actually survived and there was no amputation, but really it was very black. So we have to be very careful with this inotropic agents and especially the vasopressors. So for the dopamine, okay, we are now in the second medication. For the dopamine, usually for the central line, the concentration is 200 milligrams in 45 ml of D5 water or NS. So it's 4 milligrams per ml. And for peripheral line, just in case we need to start in the ward, it should be lower, half the dose, 100 milligrams and 47.5 ml of D5 water or NS, a total of 50 ml in a syringe, which is 2 milligrams per ml. So peripheral dopamine may be used for patients who required urgent therapy in the ward, but please do remember the maximum dose of dopamine is only 5 mics per kilogram per minute, okay? Don't exceed 5 mics. And because you are in the ward, so a patient should also be in the intermediate care unit within the ward, okay? If you have IMCU or step down, then the patient should be monitored there. So the next is adrenaline. Usually the stock of adrenaline is 1 milligram per ampule. So our dilution is 5 milligrams is in 45 ml, 5% dextrose or saline, and the formula is the same with dopamine and dobutamine, okay? The dose in microgram multiplied by kilograms multiplied by 60 per minute multiplied by the total volume, which is 50, and the stock in milligrams, so 5 milligrams multiplied into micrograms, so times 1,000, that would be your ml per hour. So if you are having in the infusion ml per hour, how you will calculate it as really if you are keen in observation, so how you will recalculate it according to the order in mics, if it is correct. So microgram per kilogram per minute equals rate in ml per hour multiplied the stock in microgram divided by the weight, the volume, and the time, okay, 60 minutes. So for noradrenaline, the stock is 4 milligrams per 4 ml ampule. Dilution for centraline is 4 milligrams in 46 ml, 5% dextrose, and the dilution for peripheral line. But we actually discourage noradrenaline to be in peripheral line because noradrenaline is more potent than the inotropic agent. This is vasopressor, okay? 4 milligrams in 246 ml, 5% dextrose or NS. So you see the difference between the central line and also the peripheral line. It's more, it's actually 250 dextrose to dilute. So the formula is still the same, ml per hour, volume, multiplied by microgram per kilogram per minute, and the stock in milligrams multiplied by micrograms, so that would be. So heparin is actually very basic for all the health institution. Okay, this is an anticoagulant medication. So we have usually 25,000 international units, which is 5 cc or 5 ml in 50 ml. So 5 plus 45, so total of 50. So how you will calculate ml per hour? So it will be the order dose, like for example, 1,000 international units multiplied by the volume divided by the 25,000. Okay, so the desired dose multiplied by the total volume divided by the stock. So how you will counter check? You just cross multiplication. Okay, then you will have your ml per hour. So Cordarone or the amiodarone infusion is an anti-arrhythmic drug. So 1 ampule of your Cordarone is 150 milligrams per 3 ml ampule, and the dilution according to the ACLS guideline, it's actually 900 milligrams Cordarone in 500 ml of D5 water. And sometimes the doctor will say 900 milligrams in 500 to run, like without even writing the ACLS protocol, okay? So keep in mind that the first 6 hours, you have to calculate it with 1 milligram. This is actually the standard. 1 milligram multiplied by 60 minutes in an hour, multiplied by 100, the total volume, divided by 900. So in your infusion pump, you will deliver 33.3 ml for 6 hours, okay? And the next 18 hours, because it should be administered at least 24 hours, 0.5 milligrams times 60 and multiplied by 500 and divided by 900 milligrams. So it will be 16.66 ml for 18 hours. So you will have your 24 hours administration of your amiodarone. And as we have discussed previously with the ACLS algorithm, the maximum cumulative dose of amiodarone within 24 hours is 2.2 grams, okay? No more, no less. So we will go for nitroglycerin infusion or the so-called tridyl or nitroglycerin, okay? It's very important, especially if your patient is having pulmonary edema, heart failure, and also patient having increased blood pressure. So the stock is different. We have different stocks. So as a nurse, you have to double check regarding this medication. as high alert medication. So we have the stock of 50 milligrams for 50 ml vial. We also have 10 milligrams per 10 ml ampule, and we have also 50 milligrams per 50 ml ampule. So the dilution, usual dilution is 10 milligrams of nitroglycerin, okay, 10 ml per 2 ml, depending on the stock, in 40 or 48 ml of NS or 5% dextrose. So the formula will be ml per hour. So the order in microgram, usually the doctors will start with 5 mics and multiply by 60, multiply by 50 ml, which is the total volume, and the stock, which is 10 milligrams. Some of the hospitals, they are using the 15 milligrams. So it depends on the protocol of your hospital, multiplied by 1,000 microgram, because you have to convert milligram to microgram. But we have to take note, titrate according to chest pain, heart rate, blood pressure, increase in small increment of 5 mics, 2 to 5 minutes, monitoring your blood pressure with each titration, win slowly 5 to 10 microgram every 15 minutes, and don't mix with bicarbonate because of crystallization effect. Why we have to win slowly? Because if you will directly turn off the nitroglycerin, again, we will restart again the medication because there will be side effect of rebound hypertension, okay? And make sure that you will not administer the patient with nitroglycerin if the patient have taken before 48 hours the medication, which is Viagra, okay? They are not allowed to take the nitroglycerin, and also if you have right RV failure, okay? Because the more that the patient will have low blood pressure. So streptokinase, okay? Streptokinase usually is before the patient will be sent in a cardiac center. Usually streptokinase will be started with the general hospitals. So the dilution is 1.5 million units of streptokinase with 100 ml of NS to be given over an hour as divided equally. So one vial is actually 75,000 units. So the first set of ECG and cardiac enzyme to be done after 30 minutes of the half of the dilution, okay, the preparation. Then second set to be sent after 8 hours and be repeated every 8 hours for 24 hours, okay. So we have ECG and cardiac enzymes. So also most common medication is the insulin. The preparation of insulin, okay, 50 units or 0.5 ml of insulin in 49.5 ml of NS. So probably some of the hospitals, general hospitals, they have different preparation for insulin, but your formula should be the same, okay? So the formula that you have to use is what is the desired. So for example, the desired is only 1 unit. So multiplied by the total volume of 50 and then fission, divided by the stock, which is 50 units, and the time, okay? So it will give you the ml per hour. So once regular insulin is open, it must be consumed for 1 month because the potency is actually within 1 month unless out of stock. Sometimes we are actually out of stock of insulin. So the pharmacy department will have a memorandum that you can extend it because of inability of the unavailability of the medication. So this will be the end of part 2. Part 3, we have drugs and calculation. Part 3, we will talk about introduction to medication safety, okay? As a nurse, please make sure that your medications, even if it is not high alert medication, but when you are dealing with medication that needs calculation, please make sure that it is counter-checked by your clinical instructor or the senior nurse that you have in your department or the charge nurse, okay? So, the rationale, medication use has become increasingly complex in recent times, and medication error is a major cause of preventable patient harm. It says here preventable, okay? So it's not necessary if you are not able to administer the medication and you have wrong dosage, this is preventable, okay? You prevent it to be given to the patient. So our learning objectives here is to provide an overview of medication safety, to encourage you to continue to learn and practice ways to improve the safety of medication use. So we have here some definitions like side effect, a known effect other than that primarily intended relating to the pharmacological properties of a medication. Example, your opiate analgesia often causes nausea, and adverse reaction is unexpected harm arising from justified action where the correct process was followed for the context which the event occurred. Example is an unexpected allergic reaction in a patient taking a medication for the first time. Okay. The error is a failure to carry out a planned action as intended or application of an incorrect plan, an adverse event, an incident that results in harm to a patient. So all this side effect, adverse reaction, error, adverse event, it needs to have an OBR. And also, there is also an occurrence variance reporting that is from the pharmacy. Okay? So an adverse drug event may be preventable, usually a result of an error, or not preventable, usually the result of an adverse drug reaction or side effect. A medication error may result in an adverse if a patient is harmed. Okay? A near miss if a patient is nearly harmed or neither harm or potential to harm. Then medication errors are preventable. Actually, I have experience with this medication error, heparin, okay? Usually when you are talking about heparin bolus, you have to administer it IV, right? So we have one patient before. I have 5 patients with me, and we have understaffed. So the patient needs bolus of, I guess, 2,500 international units of heparin, IV bolus, okay? But the patient was very old. He's 75 years old and very prone with hematomas and ecchymosis. So by mistake, I injected it sub-Q. So it is actually, excuse me, it is actually medication error, okay? The site of administration. Instead of IV, I give it subcutaneous. So I was really worried because the patient complained, okay? And when I spoke to the doctor, I told him that, doctor, I did this error. I gave subcutaneously 2,500 international units instead of giving it IV. So the doctor said, no need for you to do OVR because it's actually okay because the proper way of giving the heparin is actually sub-Q. I said, no, because this is a mistake. So nobody likes, even the head nurse, the charge nurse, nobody likes to make OVR against me. But this is actually to correct me. So what I did, I made my own OVR to myself and submitted to the quality. So the following day, I was actually not expecting the result of what I did. So the quality called me, and then they said, "Mashallah, you made your in the incident report against you. This is the first time for us that a staff is being honest to make correction to herself." I said, "This is actually a mistake which I need to be corrected by myself." So alhamdulillah, I don't have any problem because OVR is actually to correct you, okay? Unless, of course, the patient will die, there will be some actions according to the law. Steps in using medication, we have prescribing, administering, and monitoring, okay? Usually, the monitoring is what we miss as nurses. What are the side effects? What are the complications? Okay? Did the patient swallow the medication? After the patient swallowed the medication, what happened to him? Okay. Note that these steps may be carried by healthcare workers or the patient, example, self-prescribing, over-the-counter medication, and self-administering medication at home. So prescribing involves choosing an appropriate medication for a given clinical situation, taking individual patient factors into account, such as allergies, select administration route, dose, time, and regimen, communicating details of the plan with whoever will administer the medication, written transcribing and or verbal, and the patient, and also documentation. Okay. Please, for verbal, it needs to be in emergency only, that the verbal can be accepted, but when the paid doctor is available, then do not accept verbal. So they should write it and then you carry it out. So how prescribing go wrong? There will be inadequate knowledge about drug indications and contraindications, not considering individual patient factors such as allergies, pregnancy, comorbidities, other medications, wrong patient, wrong dose, wrong time, wrong drug, wrong road, and inadequate communication, verbal and non-verbal. For this inadequate communication, I also have an incident when the first time I came here in Saudi Arabia. I have for night shift, one of the staff was, it was my first time for me to encounter, sorry to tell for the nationality, but my co-staff from the night was an Indian staff. And you know the action for yes and no, right? The shaking of the head, and Filipinos also, they have different also. So I asked her, did you give the morning dose of 2 units of insulin to the patient? She shake her head. I said, okay. She did it. Then I repeat again. Did you give? So without me looking at the medication sheet, I just prepared because I thought it was no, but it was actually yes for her. And she didn't use any verbal communication. She just used an action. So I gave another 2 units of insulin. She gave 6 a.m. and then I gave at 7:30. So 4 units was given. Alhamdulillah, the patient was insulin, the RPS was resolved. When I repeated, it's actually 154. So what if it becomes high, right? Because of just inadequate communication. So we have to be very careful. Then documentation should be that if the prescribing will go wrong if the documentation is illegible. So the doctors have sometimes very bad handwriting, which we cannot understand. Also incomplete in spelling and ambiguous. Mathematical error when calculating dosage, incorrect data entry when using computerized prescribing, example, duplication, omission, wrong number. Duplication, please be careful because there are some medication, it happens to our hospital before that, a new drug, which is a different trade name, but the same generic name. And it was newly introduced by the company, okay? And the doctor prescribed the same medication twice. So alhamdulillah, the nurse who was almost giving the medication to the patient, we checked and she was very watchful with the trade name and the generic name. So it was just the same. So she referred to the doctor and alhamdulillah, one of the medication was stopped. So this is also one of our job to make sure that the doctor will not prescribe in duplication. We have also look alike and sound alike, which we are actually very, we know about this. So like, for example, Celebrex, which is an anti-inflammatory, and we also have Cerebrex, which is an anticonvulsant, and the Celexa, which is an antidepressant. So look alike, sound alike. We have the ambiguous nomenclature, like the Tigritol, S/C, so we need to write it properly. Then 1.0 milligrams, 0.1 milligram, Tegretol, 1,100 milligram, SL, 10 milligram, 1 milligram. So avoid ambiguous nomenclature. Avoid trailing zeros, write 1, not 1.0. Use leading zeros, example, write 0.1, not 0.1. No acceptable local terminology, write neatly, print it if necessary. So we have actually policies in each of the hospital for the abbreviations that we can use, approved abbreviations, so we need to check it out also. So administration involves obtaining the medication in a ready-to-use form, may involve counting, calculating, mixing, labeling, or preparing in some way. Sometimes the pharmacist is the one preparing these medications, checking for allergies, giving the right medication to the right patient in the right dose via right route at the right time, and always document, because if you will not document, that means it was not given. So how can drug administration go wrong? Of course, we have the 10 rights, right? But we have here, what we have here is the most important, the 5 rights. Wrong patient, wrong route, wrong time, wrong dose, wrong drug, and omission failure to administer an inadequate documentation. Okay. So we have here the 10 rights. So we also have added right patient education, right documentation, patient have the right to refuse, right assessment, right evaluation. Okay. So calculation errors. Okay. Can you answer the following questions? Okay. So you can turn on your mics. A patient needs 300 microgram of a medication that comes in a 1 ml ampule containing of 1 milligram of drug. What volume do you draw and inject? You have 30 seconds. Any answer?
0.3.
Who's this?
مشاعل.
Michelle, 0.3. Okay, yes. It's correct, Michelle. Congratulations. You have now 2 chocolates. So monitoring involves observing a patient to determine if the medication is working, being used appropriately, and not harming the patient. And again, it's repeating documentation and documentation. So how can monitoring go wrong? Monitoring can go wrong if there is lack of monitoring for side effects. That's why when you are actually encountering a medication which is first time for you to medicate, there is drug literature, right? So please take a look at it. At least what I'm doing before, when I first started working here in Saudi Arabia, I'm collecting all the drug literatures that I will have in the box of the patient medication and study it. And of course, since this is the first medications that you have and your exposure to the hospital setting of the country of origin you have, it's different from the one that you have it here in Saudi. So we really need to make sure that we can monitor. So you administer, when you take vital signs, this is your assessment. Then you take you give the medication, this is administration. Then after that, we need to monitor for side effects or any complications for the patient. The drug that ceased if not working of course complete, drug ceased before course completed, drug levels not measured or not followed up on, and again, communication failures. So which patients are most at risk of medication error? Those patients are on multiple medications, patient with another condition, example, renal impairment, pregnancy, patient who cannot communicate well, patient who have more than one doctor, patients who do not have or take an active role in their own medication use. Because there are some patients, they don't care about their medication. They don't even know what are their medications. Children and babies, those calculations required, and it needs body, weight, and height. So in what situations are staff most likely to contribute to medication error? Inexperience, okay? If you're newly graduate from the university and then you work in a hospital and without somebody who is teaching you, then it will be difficult because there will be no guidance. You might forget the things that you have learned previously in your school because the school and the clinical in the real scenario of work is actually different experience. It's entirely different. Rushing. So if you're given first time for you to handle 3 patients, you keep on rushing and sometimes you will have medication error. Doing 2 things at once. Okay, so sometimes you will be called by the physician to come, then you are preparing, you're not yet finished preparing your medication, and then you are called for the rounds. Okay, interruptions, fatigue, boredom, being an automatic pilot, leading to failure to check and double check, lack of checking and double checking habits, poor teamwork. This is very bad. or teamwork and communication between colleagues. So there are some hospitals that they really have poor teamwork. They don't care at all, okay? Sometimes they don't even remind the new staff, oh, it's already your medication time, it's already 12, so we need to take the medication from the pharmacy or whatever. And then if you are very busy, then they will not help you at all. Then reluctance to use memory aids, okay? So how can workplace design contribute to medication errors? So there is absence of safety culture in the workplace. So if there is absence of safety culture in the workplace and you are having in yourself a safety culture in yourself, you can start it. You will be the one to start it. Example, poor reporting systems. Not all hospitals are having good reporting system. So you need to make sure that OBR can be done, and failure to learn from past near misses and adverse events. Absence of memory aids for staff, inadequate staff members, okay? So there is also something that I wanted to remind everybody, which might be done by other hospitals, okay? Especially the narcotic. Sometimes because of the laziness or the irresponsibility of the staff, they will just remove or cover the name of the patient with a narcotic, okay? And they will change it after, but the narcotic prescription is still the same. The one prescribed there is still the same, and he or she is covering the name of the patient. And then they will make the Xerox copy, which is actually really wrong, okay? It's very wrong. In our country, in the Philippines, you might can be removed from the license from you because this is narcotic. It's very important for you to take care of narcotics. How can medication presentation contribute to medication errors? Look-alike, sound-like medications, there should be lists, and there should be something like tall letters, small letters, then also ambiguous labeling. Use generic names rather than trade names because you will never be wrong. Tailor your prescribing for each individual patient. Consider the allergies. That's why in our documentation, it's very important that you will ask the patient, Papa, what are your allergies, okay? Do you have any allergies from shellfish? Do you have allergies with shellfish? Joke. And also comorbidities, especially liver renal impairment, because most medications will go to the liver for the last risk, for the liver is the one receiving all the bad elements of the body, okay? And renal impairment, okay, will also occur. Other medications, pregnancy and breastfeeding, size of patient. So learn and practice thorough medication history taking, include name, dose, route, duration of every drug, inquire about recent disease medications, dietary supplements, and alternative medications. Okay? And make sure the patient actually takes matches your list. Be particularly careful across transitions of care and practice medication reconciliation at admission and discharge from hospital. Look up any medications you are unfamiliar with. So this is what I'm telling you, that when it is first time for you to be encountering this medication, take the drug literature. And your cell phone has now internet access, so you can actually check on that medication. And the Ministry of Health now is providing us the up-to-date, so we can also check. Consider drug interactions, medications that can resist, and medications that may be causing side effects, and always include allergy history. So know which medications are high risk and take precautions. Narrow therapeutic window, multiple interactions with other medications. So you have drug-to-drug interaction. You have also food-drug interaction. Potent medications, complex dosage and monitoring schedules. Okay. So one of the potent medication, as an example, is actually the thiazide group of diuretic. Okay, look, diuretics are the Lasix, but the thiazide group, it's really potent medication. So that's why it's usually given alternately, okay, alternative days. Know which medications are high risk and take precautions. Example, your oral anticoagulation, your warfarin, chemotherapeutic agents, your insulin, neuromuscular blocking agents, aminoglycoside antibiotics, intravenous potassium, emergency medications, potent and used in high pressure situations. So you have also to know the medication that the doctor prescribed, okay? Do some homework on every medication. So the doctors even can do homework. What is the medication that they need to prescribe? So suggested framework, the pharmacotherapy, indications, contraindications, side effects, special precautions, and dose and regimen should be actually taken consideration. And also sometimes there is also this nursing consideration. And as nurses who are just new in the field, you can use textbooks, personal digital assistants, computer programs, and some of the hospital also have computerized prescribing, but you have to check also that the prescribed medication is correct. Protocols, free up your brain for problem solving rather than remembering facts and figures can be stored elsewhere. And looking things up in unsure is a marker of safe practice, not incompetence. And communicate clearly. State the obvious, close the loop. How you will close the loop? If you will be asked, did you give 5 units of regular insulin? So you also have to say, I gave the 5 units of insulin sub-Q, blah, 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 okay? Close the loop. Develop checking habits. This checking habits is always a problem with the nurses, okay? So we have to develop checking habits, and if you are not actually practicing checking habits, you have to practice checking now. So if you're unlabeled medications, you are not sure it belongs to the bin, okay? You throw it, never administer a medication unless you are 100% sure you know what it is. And practice makes permanent. Perfect practice makes perfect. So encourage patients to be actively involved in the process. So that's why as nurses, we are usually also telling the patient what is this medication for, okay? When prescribing a new medication, provide patients with the following information: name, purpose, and action. Those, again, the 5 rights, special instructions, and how the medication will be monitored. So encourage patients to keep a written record of their medications and allergies. So before they will be discharged in the hospital, usually the patient have the medical report or the discharge summary. So make sure that you encourage them that every time they are going to the outpatient department for checkup, then they have to bring this discharge summary form. Encourage also patient to present this information whenever they consult a doctor, and report and learn from medication errors. So as a summary, medications can greatly improve health when used wisely and correctly, yet medication error is common and is causing preventable human suffering and financial costs. Remember that using medications to help patients is not a risk-free activity, and know your responsibility and work hard to make medication use safe for your patient. So the next is the calculation error. Okay, another question for you. Can you answer the question? A 12 kilogram, 2-year-old boy requires 15 milligrams per kilogram of a medication that counts as a syrup with a concentration of 120 milligrams per 5 ml. How many ml do you prescribe? You have 30 seconds. Anyone who got the answer? Who's this? Salvi. So how did you get your answer? So we have 2-year-old boy requires 15 milligrams per kilogram of a medication that comes as syrup with a concentration of 120 milligram per 5 ml. Okay. So what is your formula? So your formula. Okay. Okay. So what's your answer? I can hear only ml. Okay, 6 ml because you have to divide your 15 milligrams, okay? Your desired dose is what? 150 milligrams, right? And the body weight of the baby is 12. Yes. So your stock is 120 milligrams. So divided by 120 milligrams multiplied by 5 ml, that would give you 6.
7.5, ma'am.
Wait. 7.5, sir? So 12 times.
Yeah, it's 7.5.
No. It's not 12 times 15.
7.5.
7.5, sorry, 7.5. Because 12 here, 15 is the desired dose. Then you have it. Then 120, then the body weight is 12. Multiplied by 5 ml, it's 7.5. Who got the answer? Who got 7.5?
Maricel.
Feb.
Okay, Maricel, you have no chocolate. Maricel, you will have your chocolate, okay? Prince Sultan, mashallah. Okay, next. Example, okay? Case example. Please take note of this case example. A 74-year-old man sees a community doctor for treatment of a new onset stable angina. The doctor has not met this patient before and takes a full history and medication history. He discovers the patient has been healthy and only takes medication for headaches. The patient cannot recall the name of the headache medication. That's why it's very important for us to tell them, explain to them, and let them bring the discharge summary or medical report. The doctor assumes it is an analgesic that the patient takes whenever he develops headache, but the medication is actually a beta blocker, okay? So beta blocker and headache medication is very different that he takes every day for migraine. This medication was prescribed by a different doctor. So remember, previously we talked about different, more than one physicians. Huh? So this is actually one of the most problem for the medication error. The doctor commences the patient on aspirin and another beta blocker for the angina. After commencing the new medication, the patient develops bradycardia because it was taking beta blocker. So bradycardia developed, and of course, postural hypotension. Unfortunately, the patient has a fall 3 days later due to dizziness on standing. He fractures his hip in the fall. So what are the factors contributed to this medication error? There are 2 drugs at the same class prescribed unknowingly with potentiation of side effects. So there was 2 beta blockers was given to the patient plus the aspirin. So of course, bradycardia, if you have bradycardia, your blood pressure also decrease, your hemodynamics will become unstable, so you will have dizziness, and then he fell down because of dizziness and he fractured himself. So the patient is not well informed about his medications. Patient did not bring medication list with him when consulting the doctor, and the doctor did not do a thorough enough medication history. 2 doctors prescribing for 1 patient, and patient may have been warned of potential side effects and what to do if side effects occur. So how could this situation have been prevented? So the patient education is very important about this regular medication, potential side effects, and the importance of being actively involved in their own care and having a medication list and more thorough medication history. Another case, a 38-year-old woman comes to the hospital with 20 minutes of itchy red rash and facial site swelling. She has a history of serious allergic reactions, and a nurse draws up 10 ml of 1:10,000 adrenaline epinephrine into a 10 ml syringe and leaves at the bedside ready to use, which is a 1 milligram in total. Really, it's high dose, just in case the doctor requests it. Meanwhile, the doctor inserts an intravenous cannula. The doctor sees the 10 ml syringe of clear fluid that the nurse has drawn up and assumes it is normal saline or saline. There is no communication between the doctor and the nurse at this time, and the doctor gives all 10 ml adrenaline or epinephrine through the intravenous cannula, thinking he's using saline to flush the line. The patient suddenly feels terrible, anxious, becomes tachycardic, and then becomes unconscious with no pulse. She discovered to be in ventricular tachycardia, is resuscitated, and fortunately makes a good recovery. Recommended dose of adrenaline in anaphylaxis is 0.3 to 0.5 milligrams IM, and this patient received 1 milligram IV, so direct IV. Almost they killed the patient. So what are the contributing factors of this error? Assumptions. So the doctor, because there was no labeling, he has have assumption that this is plain saline solution. Then lack of communication. He didn't even call the nurse who prepared for the syringe if what is that, medication or plain saline. Then inadequate labeling of syringe. So it should be labeled, okay? Giving a substance without checking and double checking what it is, and lack of care with a potent medication. So how to prevent this error? Never give a medication unless you are sure you know what it is. Be suspicious of unlabeled syringes. Never use an unlabeled syringe unless you have drawn the medication up yourself. Label all syringes and communication. And develop checking habits, okay, the 5 R's. And the doctor should also ask the nurse what is in the syringe. So another case example, which you have to take note, a patient is commenced on oral anticoagulants. Anticoagulants is always, in every hospital, a patient can be given anticoagulants for treatment of a deep venous thrombosis following an ankle fracture. The intended treatment course is 3 to 6 months. Through neither the patient nor community, doctors are aware of the planned duration of the treatment. So the patient is having anticoagulant, and it should only be until 3 to 6 months, but there was no communication, okay? Patient continues medication for several years, being unnecessarily exposed to the increased risk of bleeding associated with this medication. So the patient is prescribed a course of antibiotics for a dental infection. 9 days later, the patient becomes unwell with back pain and hypotension, a result of a spontaneous retroperitoneal hemorrhage requiring hospitalization and a blood transfusion. International normalized ratio, or the INR reading, is grossly elevated. Anticoagulant effect has been potentiated by the antibiotics. So you have to be very careful with your anticoagulant plus the antibiotic. So what are the contributing factors for this medication? Lack of communication and hence of continuity of care between the hospital and community. So even the community doesn't know that it's only 3 to 6 months treatment. Patient not informed of the plan to cease the medication. The interaction between the antibiotic and anticoagulant was not anticipated by the doctor who prescribed the antibiotic, even though this is a known phenomenon. So please make sure now you know that anticoagulant plus antibiotic, there is a potentiation of side effect. Lack of monitoring. Blood tests would have detected the exaggerated anticoagulation effect in time to correct the problem. So if, for example, the patient is taking warfarin, there is certain time that you have to take the INR result. So there was no blood test, regular blood test done to this patient, which is also the contributing factor. So how could this error have been prevented? Again, effective communication. So the discharge summary should be actually sent to the community doctor. Memory aids, alerting systems to help doctors notice potential adverse drug interactions. then being aware of common pitfalls in medication you prescribe, monitoring medication effects when indicated. By the way, there is now an application that during this COVID-19, I forgot the name of the application. I guess some of the Saudis knows about this. That whenever a patient who is actually having some medications and they don't need to go to the hospital, but instead with this application, they can take the medication in one of the pharmacies outside. Like I don't know if Aldawa is also included, but there is a pharmacy which is actually under the Ministry of Health. They are, if it is the patient doesn't need to go to the hospital, but instead by the system, this pharmacy can give to the patient directly. There are lists of the medications that available in that certain pharmacy. So how could the patient help prevent this error? So the patient should also ask the doctor, "Doctor, how long will I need this medication for?" So if you are having a patient, your family is one of the patients and you are the one who is the one moraphic for the patient, of course you will also help to ask, and will this antibiotic interact with other medications? And how can the doctor encourage the patient to ask more questions? So this is also, we are encouraging the patient to ask more questions. So regarding the intravenous medication, so we have IV fluids delivered directly into the bloodstream via a vein. It includes solutions, medications, and blood, okay? And it has rapid effect. The result can be fatal if wrong medication or dosage is given. So what are the IV solution functions? So we have here for replacement of electrolytes, fluids, sometimes also to give the patient vitamins, maintenance, fluid balance, electrolyte balance, and to keep the vein open just in case the patient might need emergency drugs, and maintain an IV line. Therapeutic delivers medication to patients. So this KVO is actually very important. Sometimes even our patient doesn't even have an IV fluid going on, but still there is peripheral line open, because we have some experiences before that a patient who is for discharge already, but before the discharge, the patient becomes unconscious and there was no IV. We remove already the IV line prior to the discharge. So to prevent this incident to occur again, so most of our patients who have medications before through IV, we are not removing unless we are sure that the patient is already going to go home. He will be on the wheelchair already. So just in case that there will be something happen to the patient again, directly we have an open line. So please make sure that you will know the labels of your IV solutions, okay? The solutions have its name of components and the exact amount of the components. So see this label, lactated ringers and 5% dextrose injection, 1000 ml. So we need to remember that in abbreviations for IV fluids or IV solutions, letters identify components and numbers identify concentration. So example, we have 5% dextrose in lactated ringer solution might be abbreviated in any of the following. Okay, D5LR, D5 in big number, and D5LR small, 5% D/LR, they are all the same. So D10 water also can be 10% dextrose in water. D5 water is 5% dextrose in water. W or water, it's the same. NS and SS, the same with 0.9 sodium chloride. LR, lactated ringers. RL, ringers lactate, it's the same. So we also have the half and half NSS. It's actually 1/2 normal saline solution or 0.5% sodium chloride, 1/3. So it's all the same in meaning what, then the abbreviation plus the solution there. So 5% dextrose This is the exam, like the quiz or the one of the examples before that you have to calculate. 5% dextrose contain 5 grams of dextrose per 100 ml. So if it is 5%, so 5 grams dextrose per 100 ml. So what does it mean? In 500 ml, so we have 5 times 5, because we have 500 ml, so we have 25 grams of dextrose in 500 ml of the IV. So how about the NS or normal saline? So we have 0.9%. If 0.9%, if there is 0.9, it pertains to milligram. But if without, it's directly 5%, it is directly 5 grams. Okay, so it contains 900 milligrams or 0.9 grams of sodium chloride per 100 ml. So that means we have 900 or 0.9 grams times 5, so that it would mean some 0.45 or 45 grams, okay, or 900 milligrams times 5, so it will be 4,500 milligrams of sodium available in the 500 ml of NS. So we also have the NS, normal half normal saline, or the so-called 0.45% saline, contains 250 milligrams or 0.45 grams of sodium chloride per 100 ml. So now you know that how you are going to calculate, okay? So the choice of solution is based on patient requirements. We have different types of solution. We have isotonic solution. It do not affect fluid balance of cells and tissues. Some of the example is D5 water, NS, and LR. Hypotonic IV solution, more fluid into surrounding cells and tissues, restore proper fluid level in cells and tissues, and used to correct dehydration. So we have 0.45 NS, 0.3%. So if your doctor will tell you, sister, you have to give us, can you give us isotonic solution? So isotonic solution, NS and LR. It's not actually irritating the blood vessel. And hypotonic, to correct dehydration. Hypertonic, draw fluid from cells and tissues into bloodstream and used to correct severe fluid shifts, especially burns. So 3% saline is one of the example. So patients with normal electrolyte level are likely to receive isotonic solution. So how you will identify that it is an isotonic solution? By looking at the label of the IV. So if it is 250 to 375 MOSM per liter, so that is isotonic solution. And if patient with high electrolyte levels will receive, you have less 250 MOS M per liter. So this is hypotonic solution. And the patient with low electrolyte levels will receive hypertonic solution, which is more than 374 MOSM per liter. And this can be seen in the label of your IV. Please take note of this equivalent electrolyte content. It's very important for you. The additives, we have medications, electrolytes, and nutrients. If not prepackaged, we'll have to mix. Okay? So before combining any medications, electrolytes, or nutrients with an IV solution, be sure the components are compatible. Compatibility is very important. So example of incompatible medication or solution, ampicillin is not compatible with D5. So avoid giving medications in site wherein D5 water is ongoing and you are giving ampicillin. It's actually incompatible. And also the ciprofloxacin sodium should not be administered together with sodium bicarb. The diazepam also will not be delivered or administered with potassium chloride. Dopamine should not be with sodium bicarbonate. Penicillin to heparin penicillin to vitamin B complex, sodium bicarb with LR, tetracycline with calcium chloride. Most of the effect will be crystallization or the whitish crystallization. So we'll go to the inotropes. Okay, we'll just make it fast. So inotropic agents which increase or decrease the force of energy of muscular contraction. So it was actually the first inotropic was discovered in 1785, which is the digitalis. Then we have 3 clinical approved inotropes, cardiac glycoside, and most common is digoxin as an example. Sympathomimetics, so we have your epinephrine, dopamine, dobutamine, norepinephrine. So both what we call this, the vasopressor and the inotropic agent. And we have the phosphodiesterase inhibitor like amrinone and milrinone. So for the cardiac glycoside, the first line of inotropes include all digitalis derivatives, okay? And indirect effect on the cardiovascular system regulated by the autonomic nervous system, which is responsible for the effect on the sinoatrial and atrioventricular nodes. So we also have the direct and indirect effects are an increase in force and velocity of myocardial contractility, which is positive inotropic effect. A slowing of heart rate, which is a negative chronotropic effect, and decreased conduction velocity through the AV node. So for the sympathomimetic or adrenergic, the drugs are exerting potent inotropic effects by stimulating beta-1, alpha-1, and alpha-2, and dopaminergic receptors in the myocardium, blood vessels, and sympathetic nervous system. So please do take note of this. When we are talking about alpha-1 receptors, these are receptors in the vascular smooth muscles and also in the myocardium, which mediate positive inotropic and negative chronotropic effect. Okay. So myocardium and smooth muscle. For alpha-2, it's located in large blood vessel. Sorry, it's written alpha-1. It's supposed to be alpha-2. So alpha-1, the receptor, the medication is actually acting in the vascular smooth muscle and myocardium. And alpha-2 in the large blood vessels. Stimulation of alpha-2 receptors mediates arterial and venous vasoconstriction. So if you have your low BP, it will increase your blood pressure. So if you are talking about beta-1, well, sometimes you can hear, what is alpha-1, alpha-2, beta-1, beta-2, okay? So beta-1 receptors increase heart rate and myocardial contractility. Beta-2 receptors enhance vasodilation, relax bronchial, uterine, and gastrointestinal smooth muscle. So it decreases heart rate and blood pressure. Dopaminergic, it's related to the effect of dopamine. So we have here a dopamine. It is possessing alpha and beta and dopaminergic receptor stimulating action. The specific effects are related to the dose delivered. So it depends. The dopamine can, the doctor will order according to the required effect. So we have here low dose of 0.5 to 2 microgram. It actually promotes blood flow and increase glomerular filtration rate. So sometimes a patient may not have, we might have decreased urine output. So usually they started with the renal dose, which is 5 microgram. So here, please take note that the urine output may increase without significant effect on blood pressure or heart rate. But you have a warning here. Correct hypovolemia first prior to administration of dopamine. Do not infuse peripherally. And extravasations can cause severe tissue necrosis. Monitor the patient carefully for decreased circulation in the extremities. So if extravasates into tissues, okay, vasopressors, inotropes, or inotropic agents, if there is extravasation and it causes mild from mild necrosis, this is the the medication that should be given to the patient to avoid developing it more disastrous effect. So the doctor should infiltrate, okay, and should order with 0 to 15 ml of 0.9% sodium chloride containing 5 to 10 milligrams of pentolamine. Pentolamine is then administered sub-Q in the 490 quadrants around the site of extravasations. So this is how to prevent the necrosis. So dobutamine, it's actually chemically related to dopamine, synthetic catecholamine, stimulates beta-1 and alpha-adrenergic receptors, and increases contractility, stroke volume, and cardiac output. And the dobutamine mechanism also includes decreased preload and afterload by having vasodilation effect, produces mild chronotropic, hypotensive, and arrhythmogenic effects, increase renal mesenteric blood flow by increasing cardiac output, and does not affect renal blood flow like dopamine. So it will not increase the urine output. So these are the doses. This dose will not increase heart rate or cause vasoconstriction. Maximum dose, please do remember, maximum dose of dobutamine administration is 20 microgram per kilogram per minute. So if your doctor will say, give 25, please do not accept the order because the maximum dose is 20 mics only. So warning, increasing the rate past 20 microgram per kilogram per minute could be detrimental. You see, it's dangerous because myocardial oxygen consumption can cause tachycardias, and possibly your patient will develop arrhythmias, blood pressure fluctuation. Then there will be myocardial ischemia. Some others will develop headache, nausea, tremors, and hypokalemia. For the norepinephrine, the most common trade name is Levophed. Endogenous catecholamine released from the nerve cells synthesized by adrenal medulla, metabolized mainly by the liver. It is a potent alpha receptor antagonist, leads arterial and venous constriction. So it increases also the blood pressure. Minimal effect on beta-2 receptors, increases myocardial contractility due to its beta-1 adrenergic effects, effective in septic shock and neurogenic shock after adequate hydration. It also increases blood flow to the major organs, including the kidneys, and helps in increasing urine output. So there is also dopaminergic action with this medication, norepinephrine. Same with the dopamine. So these are the doses. Doses greater than 30 microgram per minute might be required during shock. Contraindication, hypovolemic and cardiogenic shock because potent vasoconstriction is already occurring. Pregnancy, hypoxia, hypovolemia, secondary to fluid devotion with hypertension, and hyperthyroidism. Pregnancy because it can cross the placental barrier and can cause abnormality to the fetus. So nursing implication, extravasations produces ischemic necrosis and slowing of superficial tissues. Use of central line is recommended. Rebound hypotension occurs if it is discontinued abruptly. So same as nitroglycerin, you should decrease the rate every 5 minutes. Its use should be temporary. Monitor for bradycardia or arrhythmias. The patient should be always in cardiac monitor for monitoring. All patients receiving inotropic and vasopressor should be on any antiarrhythmic drug should be monitored. So we also have the isoprene. It has fewer beta-adrenergic receptor activity. It increases heart rate and contractility and causes peripheral vasodilation. So if there is peripheral vasodilation, of course, the blood pressure decreases. It's used for temporary control of symptomatic bradycardias, initial drug of choice for heart transplant. It actually increases myocardial oxygen requirements, and the possibility of inducing or exacerbating myocardial ischemia is present. The risk of arrhythmias is also increased, and it is first treatment of choice for bradycardia. Isoproterenol, atropine, epinephrine, or pacing should be initiated before administering isoprene. The dose, we have these doses, and decreased rate if PVCs or ventricular tachycardia is noted. Sorry for the spelling. Warning, may exacerbate tachyarrhythmias due to digitalis toxicity and may precipitate hypokalemia. So the patient also may receive amiodarone. This is actually we discussed before. It is also a class 3 antiarrhythmic and is used for various tachyarrhythmias. This time, for all the tachyarrhythmias that we have, amiodarone is always the first drug of choice in the new guideline. Indications, supraventricular tachycardia and ventricular arrhythmias. For SVT, we need to identify if it is narrow regular or narrow irregular, and also wide regular or irregular. And of course, for the SVT, we don't give directly if the patient is stable. We don't give directly amiodarone, but instead we have to do carotid massage. For the carotid massage, only one side of the carotid will be massaged at least 10 seconds. Please to remember, 10 seconds. And if the patient, as we discussed in the ACLS previous time, that if the patient is having hemodialysis catheter and there is bruit, please do not attempt to do carotid massage. And we can give the adenosine and then beta blocker or calcium channel blocker before the amiodarone. So warning, amiodarone should not be used in individuals with polymorphic BTAC as it is associated with prolonged QT interval, which is made worse with antiarrhythmic drugs. Amiodarone should only be used after defibrillation or cardioversion, and the first line of drugs such as epinephrine and vasopressin. Vasopressin now, that it's not anymore used according to the Saudi Heart Association algorithm, have failed to convert VT or VF, okay? So after the second defibrillation, if you have a patient with cardiac arrest, pulseless arrest, of course, as what we discussed previously, the patient will receive epinephrine. On the third dose or the third shock, the patient will be started with amiodarone. So these are the dosages. It should not exceed 2.2 grams for the cumulative dose within 24 hours, okay? And I forget to tell you that if the doctor will order the patient amiodarone 900 to run 24 hours, so, and he's not writing with the guideline, which is 1 milligram for the 6 first hours, and then 0.5 milligrams for the next 18 hours. If it is not like this, I asked one of our instructors before, Dr. Hani Shaheen, he said it's okay because it will be 21 ml per hour, I guess. So it's okay for as long as the cumulative dose will not exceed 2.2 grams. So warning for tachyarrhythmias rather than life-threatening expert consultation should be considered before use. Amiodarone should only be diluted with D5 water and given in an inline filter. But since our patient is actually mostly diabetic, so they're putting it in a normal saline. An infusion exceeding 2 hours must be administered in glass or polyethylene bottles containing D5 water. So this is the dose. So we have only 15 minutes. So these are the doses also. Anyway, the doctors are the ones responsible for the dosages. The only thing for you is properly calculate the dose and the amount that you have to deliver in ml per hour. So warning, discontinue a lidocaine infusion immediately if signs of toxicity develops. Lidocaine toxicity includes liver dysfunction, low protein, and acidosis. So daily we have to check the biochemistry of the patient. And also, patient might have ABGs. So atropine is the first line to treat bradycardia. And the maximum dose is 3 milligrams per atropine. 6 ampoules will it be. So warning, atropine should be avoided in hypothermic bradycardia, and it will not be effective for Mobitz type 2 second degree block type 2. And atropine should be used cautiously in the presence of myocardial ischemia and hypoxia since it increases oxygen demand of heart and can worsen ischemia. So we also have adenosine. Adenosine, as we have discussed before, is for primary treatment of SVT. We need to have ECG before, ECG during, and ECG after. So monitoring is very important and it should be given rapidly because the half-life of adenosine is only 6 seconds. So warning, some side effects of adenosine include flushing, chest pain, tightness, brief asystole or bradycardia. Brief asystole will be actually happen after the administration of adenosine. Then it will go back to the normal rhythm. Okay. The dosing, we have already discussed this 6, 12, 12 in the new guideline. And I just want you to remember this, that the relative potency of vasopressors or inotropes, we have here dopamine. So it actually increases heart rate and it also increases contractility, but it will not do vasoconstriction. It can cause vasodilation and it has dopaminergic effect, which increases urine output. For the norepinephrine, can increase heart rate, contractility, vasoconstriction, but it will not cause vasodilation and no dopaminergic effect. For the butamine, it is usually increases heart rate and contractility, so that means the heart muscle will be contracting effectively, vasodilation. It decreases blood pressure to 2+, and isoproterenol, we have heart rate, increased heart rate, contractility, and it has vasodilation effect. Epinephrine, it will increase the heart rate, it will increase contractility, it has also vasoconstriction effect, and also at the same time vasodilation and no dopaminergic effect. For phenylephrine, so it can cause vasoconstriction. Vasopressin, it can cause vasoconstriction. Milrinone, if you hear this medication, it has cardiac, increases heart rate and also contractility. So this is the end of part 3, and thank you very much for being with me. Copy of these slides, inshallah, will be given to your clinical instructors. And inshallah, next time, by January, we are trying to prepare for activities with CME hours, inshallah. Okay, any questions, violent reactions? From the participants, did you learn something today? Hello?
Yeah, we learned a lot. Thank you very much.
Okay, thank you very much also for your time. And inshallah, if there is no COVID-19, we'll see you inshallah personally for have another lecture which could help us in the future to improve our competence in theory and also in skills. Thank you very much and bye. Have a nice day. Have a nice weekend.